Thank you for that lovely welcome, Sandy. And can I just get a show of hands? Patients, physicians? Patients first? Physicians? Allied health? Okay, there's a mix here. Okay. I've taken over the EDS, the GoodHope Ehlers-Danlos Clinic at TGH now, and I took that over about April of last year. And so all I want to share with you is a little bit about the journey in terms of where we are here today and where we're going to head to in the future. And so I think, one of the things that's important for patients in particular with EDS is I think kind of a lack of hope in general in terms of often when they get their diagnosis. And so we've really put a lot of effort into figuring out how this clinic helps the patients that have access to this clinic cope with their lives and kind of move forward. And I was struck when I was in Ghent last year at the international conference that there was a lot of talk about patients and diagnoses and outcomes and what happens to them, but not a lot about how we integrate and how we help change things. And so I hope that over the next 20 minutes or so, you see that what we're doing hopefully will pay off in the future. And so in terms of my disclosures, I have no disclosures in terms of anything that we're going to talk about today, and clearly no commercial relationships. So I'm going to share with you a little bit about the team. And so the team, when I took over the program, were two individuals. It was a rheumatologist, Maida, she's a lovely rheumatologist, and Leslie Stover, who is a physiotherapist. I'll share with you where we are today and where we're heading. And so in 2017, the clinic saw about 239 patients in its first year. It was up on the 12th floor in the Peter Munk building at Toronto General Hospital. Embedded in that clinic are multiple other clinics, nephrology clinic. My own transitional pain program is in that space. There's, I think, some ID physicians there, et cetera. So it was kind of tucked in amongst others. And so through the generous donation, and I see Mark Feldman sitting in the room as well, we were able to not only move the clinic out of the 12th floor and into its own space located on the 5th floor, we now were able to move the clinic from just a couple of days to 5 full days of, 5 days of activities. They're not all full yet. We're going to get there at some point in time. And so, this is just a snapshot of a few of the individuals that are on the team, and many of them are sitting kind of as a crew over there. I'll just move from, I guess, your right to your left. That's Yvonne C. She's one of the GI. I'm standing there in my pajamas from the OR. Dr. Weinrib is the psychologist next to me. She's a fantastic clinician. She's part of my transitional pain program, has done some fantastic work in terms of ACT-based teaching. That's Max, who's also a fantastic psychologist, trained in probably one of the biggest pain programs in Seattle in the US. Dr. Mattal, who you will get to know over time. Laura McGillis, our nurse practitioner. That's Leanne McLean next to Laura, who is our overall program manager. Our new admin assistant is Oksana. She's the second from the left. And Camila Flam, who, to her credit, is going to go back to Quebec and build an EDS program there once she's finished her fellowship with us. And we will have this fellowship opportunity rolling forward over the next several years. We've had visitors from New Zealand come and spend 3 weeks with us to see what we're doing here and what's different. And why did they choose us compared to some of the other programs? Probably because what we're doing is a little bit different than what's out there, and we'll hopefully be able to continue to grow this over time. When we look at who else is in the clinic right now and who you have who you have access to, you're looking at the people I just talked about. We have a dietitian now who's solely based and looking at and her 2 days a week, looking at potential pathways in terms of a lot of the gastroparesis issues that you're dealing with. And when we searched the literature, we really couldn't find any specific templates that seemed geared towards patients like yourself. Our psychology teams, we have a kinesiologist, Stephanie, who is a PhD kinesiologist, and Laura Lopez, who I think will be here at some point this weekend as well for some of the PT lectures that we'll be having tomorrow in particular, cardiology, respirology, and we do have neurosurgical support. We had a meeting with the ministry earlier this week, and I think things are moving along there. So where are we today? 722 patient visits were in 2018. We have already had over 1,000 visits this year, and those numbers are continuing to grow. The wait times, which were 18 months to get into the clinic, have dropped to about 13 months, and we'll continue to work on that. But clearly, being the sole hub of the province, that isn't probably going to move super fast. But once you get into the clinic, the story is different. And so, that 18-month wait list to see one of our psychology clinicians is now dropped significantly. We'll get you into the physio-kin program within about 3 months. And due to Dr. Rachinsky, who's up there, who trained with myself as well, you have two chronic pain-trained individuals associated with the clinic, as well as the other waits for the other physicians are quite reduced at the moment. So there's Laura. She's probably the person that you're going to be most in contact with in terms of follow-up and connecting with what's happening in the clinic. She does a lot of our triaging, and we've gone from just lining up the referrals coming in to a bit of a prioritization in terms of individuals who are at higher need. We can talk about that a little bit later if you choose to. She's really been involved with creating our research ethics approvals, and we are pretty close. She has a manuscript. She's the first author of a manuscript looking at the diagnostic criteria since 2017, which we hope to have that out to the world. It'll be the first GoodHope branded paper, and we have a series of papers to come after that, looking at developing some educational programs as well as communicating with you and the community, et cetera. So Laura's pretty integral to what we do. These are the two individuals that will probably be of the most benefit to the patients that come through the program. I always say in all of my programs, the docs and the subspecialists, we do the easiest part of the work. There isn't a complex medical condition at all, no matter what the diagnosis is, where the psychology piece isn't the biggest piece in terms of coping and functioning with your life long term. And so there's a lot of angst when psychology leads programs, but it's actually the best programs to land in, because unless you have some hope and you can cope, there probably is no way to move forward. And I didn't mean to make a rhyme there, but I certainly did. When we talk about what you're actually going to do when you're with the psychologist, a careful assessment in terms of why you're there, understand all of those antecedent stories. And the one thing I will say is, when I was in the pain world and I would see the odd EDS patient, it was very different when I did a pain clinic with EDS patients. And you couldn't move past that 45 minutes of trauma in terms of how you either got to your diagnosis or the story or the path or the journey you're on in terms of your diagnosis and all of the issues you're dealing with. And there's no doubt that anxiety, depression, emotional dysregulation, and this chronic suicidality piece is a part of many of the complex comorbid diagnoses associated with any chronic condition, but definitely has an undertone in Ehlers-Danlos Syndrome in particular. We're really focusing on group-based programming, and it often has a little bit of angst when we talk about the group-based programming, but I can tell you that the folks that engage really like it and really enjoy it. And one of the things we know is that there's a lot of isolation in terms of being diagnosed with EDS in particular. And so what are we doing? And I say this often in the pain world, and Sandy said, I get a lot of credit, but I get a lot of criticism as well. And the one thing that I do not focus on is, how much pain do you have? And what's your pain severity? It'd be great if I could promise you that I could take it away, but I know that I won't be able to take it away. And, I've had patients come and talk to me and tell me that, Dr. Clarke, I've been in your pain clinic for about 2.5 years, and you've done nothing for me. I said, oh, really? But you're still coming back. And then they said, yeah, but my pain's still, 6 out of 10 and it's not getting better. And I said, 2 years ago when you came to my clinic, you were wheeled into my clinic, and today you rode your bike into my clinic. And so again, if we move the focus off of the severity of your pain and your functioning, I think that's a bigger win for individuals. Of course, we'll try to help with your severity, and I can promise you maybe a 15 to 20% reduction, but I certainly cannot promise you the holy grail of taking your pain away. And so, starting with that premise is really important. So what we focus on is doing what matters to you. And so, I always say, if you see us and then you see us again in 3 months, if we haven't enabled at least a little bit more improved function, then we'll take that criticism in terms of, what do we need to do next to help that move forward. I think one of the most exciting areas that we're moving into, and you've got some pretty neat pictures up there. And so Stephanie's sitting on the corner there. Laura Lopez will be here. Alyssa, she's on mat leave at the moment. Daniel Santamina, an excellent exercise scientist, and we all know Dr. Matal's face there. And, this gear program that we're going to build, I think is very different. And I know Dr. Chopra is up next, and I'll be introducing him. And I don't know that we fit the path that is described in terms of, well, don't do it too much, it hurts. We're not going to injure individuals, but we want to ensure that we know where your baseline is, and everybody can get better from a functioning perspective. And so starting at whatever baseline you are, whether you are in your wheelchair, whether you are a high functioning individual with EDS, figuring out whether we can improve that is where we want to get. We have spent over $100,000 in equipment to start to understand this at a level which no other program in the world is actually doing. So bear with us as we get some of this data over the next several years. And so what are we actually going to be doing in the clinic? You'll be assessed by one of the docs, whether that's Dr. Achinsky or Dr. Matal on the intake side. And then, or Laura, sorry, on the intake side, and then you'll be, triaged into the areas that I think that they think are going to be important to move you forward, and not all at once, but perhaps several parts of the program at different times. And one of the things we do want to do is move towards and to whatever you can do as an individual. If you can come into the hospital and do it, great. We know how difficult it is for you to get up in the mornings and get in to see us. So if it's a home-based program, so be it. But we certainly want to be able to follow the improvements in terms of the protocols that we're going to be working on. And we're talking about everything from just basic functioning to specific cervical physiotherapy, which doesn't actually exist at a high level for folks like yourself in particular that are struggling with that neuraxial spine issues in terms of muscles, et cetera, in those areas. And won't touch too much in terms of the facility-based exercise because we're working on some of these and even these one-time consults in terms of healthy living, et cetera. So what's new? I think where we're going to get to is what I think a lot of the population was struggling with in terms of, in Ontario in particular, was finding access to somebody who would provide them with what they thought they needed at a specific time in their life. And there really was no recourse. And so we've created a system where at some point in time, if you're really stuck, we will call on our experts and start these multidisciplinary case conferences. And whether that involves the neurosurgeons or the cardiologists or the other subspecialty physicians within the clinic, that will be determined on a case-based scenario. So you don't have to feel so lost in terms of why something's not happening. Of course, the bottleneck is still you've got to get into the clinic and get through our doors. Dr. Chopra spoke yesterday. We're going to have hopefully a continued series of lectures over the next several years as we roll things forward. We have formed a patient and a family advisory group. So we are meeting 3 times a year with individuals who've come through the clinic to talk about how we can better tailor what's going to happen to some of the needs of the patients. And obviously the biggest missing link here, I think, is this integration with family medicine and the GPs in primary care and how we start to maybe disseminate some of the knowledge that we're going to learn. And I can tell you, we've always seen a bit of a shift. And Laura can attest to this in that, the GPs are now sending patients with questions as opposed to with diagnoses. And so I think that'll be a positive move for the population in general as we move this forward. So talk a little bit about what's different from a research perspective. And so we certainly have put together what we think a clinical pathway might look like. And we're going to be researching that with a broad-based prospective approach to see how the patients that flow through the clinics are. And you can see this is going to be a volume of data when we're seeing over 1,000 patients a year. So bear with us. I know when you come into the clinics, you're going to be asked to fill out questionnaires, and we're going to look to move that off of paper. And I'll show you a few slides on that in a few minutes. But this is really going to be critical to move the literature forward for your population, which clearly there isn't enough of as we speak. And what's any disease? If it's a rare disease, and I know there's now debates as to 1 to 3% of the population. Well, if it's 1 to 3% of the population, it's no longer a rare disease. So that's going to be an interesting discussion as things move forward. from a basic science perspective, what are we talking about? We're talking about your tissues, we're talking about collagen, we're talking about the matrices and how those things get involved. And where is an animal model for any of these? And where do we actually start to build therapeutic potential interventions from any of these? And so Dr. Mittal, to his credit, has started a collaboration with some of the folks in the dentistry building to maybe perhaps go after some of these modeling, some of these basic science models, to look at some of the underpinnings and potentially get to some therapeutic angles. That's the long road, but we're at least the start. And, I think it's clear, just having started to see more of EDS patients, and I haven't done a clinic in a while, and yes, I will do a couple next year, in terms of where this all started. And, there are stories of potential viral illnesses. There are stories of potential medications that were triggers. And ultimately, the hormone issues, a lot of that, pubertal type time where the estrogen levels start to increase. We know that affects your tissues. And where's the research in terms of any of these three possibilities? And so, these are clearly areas that we're going to be looking at as time rolls forward. Again, I've mentioned the link here to the collagen matrix and some of the basic science work that we're pursuing. There's already been a couple of grants submitted, and through some generous donations of Mr. Feldman and some of his colleagues, we will have the ability to start some of this work with or without the successful winning of some of these grants. There's some excellent GI data and gastroparesis data in terms of things like hypnosis and some of those areas, and we've put in applications to the ILC. And again, whether or not these things are funded, we are going to have the ability to move forward with some of this work. So again, I mentioned the paper-based questionnaires, and you're all frustrated with these things, and what we're hoping to do is to move from there to here. This is a company called Managing Life that I have rolled into my transitional pain program. You will hopefully be moved into this. It's a complete fight with any institution to do this because they are a third-party kind of app, but we're hoping to have our questionnaires embedded into a program. You can have it on your mobile app. We can then cross-talk, and the data you give, the data you put into the program, we'll be able to see. And what is the biggest shortcoming of any outpatient program? Well, it's that I send you on your way and I write you a prescription, or I tell you to do something and I never see you again for 3 months. And there's a lot that happens in that time period. And so hopefully closing some of those gaps will be helpful as we move this forward. And so I'm hopeful that because we've gotten through some of the hurdles with my other program, it won't be as difficult. But the problem is it then makes it solely a research-based plan. And I'd like to get this more clinically integrated. So it may not happen in the next month or two, but hopefully over the next year or so, we'll be in a place where this becomes a little bit more seamless. Okay. This is the website. We've put a lot of effort into updating the website, keeping the team updated. Unfortunately, it's kind of ugly, I know, but we're stuck with our UHN template, and that's just as fancy as we can get at this point in time. But what we have done is we've really put in the resources for the family docs to understand what needs to happen from a referral perspective and understand what's going to happen when you get to the clinic and what the expectations are. And so there's no doubt in the first year, Meta was really struggling with a lack of positive expectation outcomes from patients. To say that delicately, there were a lot of calls to patient relations about the clinic and what has happened. And so we're really making it clear what's going to happen as you roll into the clinic and have your initial assessment. Okay. So I think, to set up this, one of the things that, was really important to us is to start to change the face of what EDS actually is. And there is such a large phenotype of individuals struggling with this disease. And you have the individuals who basically have all of the POTS and the autonomia symptoms and are unable to stand, but you also have the high functioning individuals. And so, I think one of the messages that individuals that get diagnosed with EDS lack in terms of messaging is that there isn't one trajectory once you've been given this diagnosis, and there are so many things that you can help with, both with the physician help and subspecialty help, et cetera, but also from a self-management perspective, et cetera. And so we put a lot of time into developing the messaging and to help individuals like Mark go out and help fundraise, as well as our foundations at the hospital to go and help fundraise, because at the end of the day, we can't do a lot of the work we're hopefully intending to do over the next 5 to 10 to 15 years for this population unless we have some funding to help that. And so I hope you enjoy this. This is something we literally just finalized yesterday.
So growing up, I played volleyball at a high level. I kept getting injured more and more than any other player. And coaches kept coming up to me and saying, "Why are you getting so injured? You must be making it up."
Having an invisible disability, it's hard enough for people on the outside who can't see it, but it's even harder when you're in your own body and you can't see anything, but you can feel yourself falling apart at the seams.
Ehlers-Danlos Syndrome is a hereditary genetic disorder which affects the connective tissues of our bodies. Connective tissue is the glue which holds our body together. Most commonly, patients have loose, painful joints. However, some of the patients can have severe, devastating complications.
Imagine walking along, honestly, trying not to let knees and hips and shoulders pop out since you were a kid, and having them pop out anyway.
There's quite a big variation of symptoms and symptom severity that patients unfortunately go through, months and sometimes years being misdiagnosed with other conditions.
It ends up being just years of doctor's appointments that go nowhere, and then their symptoms get worse, and it sort of is an escalating process.
So GoodHope EDS Clinic is Canada's first and only interdisciplinary clinic which is targeted specifically to patients with EDS. We have an interdisciplinary team of multiple medical subspecialists who can help manage the multisystemic issues of patients to have a better quality of life and function.
One of the things we're really focused on, which is very unique in comparison to other clinics around the world, is that we are hoping to give them a sense of hope and show them that there are multiple trajectories and multiple faces of the disease.
Our clinic focuses on asking some questions that have never been asked in patients with EDS.
I think the GoodHope Clinic is unique in the sense that it's really trying to provide a home for these patients.
I have been able to see a kinesiologist who understands me and is able to give me exercises that don't hurt me. I have access now to more resources than I ever knew existed simply because I'm in the EDS GoodHope Clinic.
Being associated with the clinic and getting the resources not only connects me to physicians who are knowledgeable in EDS, but gives me the resources to educate others as well. And the knowledge is expanding because of the GoodHope Clinic to anyone that the patients come into contact with.
We are here to give support, to give advice, and most importantly, to come from a place of respect and understanding that the people we work with, they're the experts on their experience.
We're seeing the patient as a whole and working to develop a plan of care that is not going to be beneficial just for that patient, but for the EDS population as a whole.
This kind of research requires a lot of resources, starting from setting up a wet lab to getting sophisticated equipment.
Research money that's contributed towards Ehlers-Danlos will go directly towards these programs, and it will go directly towards the betterment of this patient population.
With more funds, we'll be able to offer increasingly a bigger amount of services, and we'll also be able to reduce the wait time for our patients.
It's the common.
So anyone who donates money to us goes into either clinical treatment-based research or basic science research. The basic science research would help us establish a clear-cut diagnostic test which will help get the patient's diagnosis in a timely fashion.
Being able to proactively manage has just really improved my life in every possible way, from how I eat, how I work out, how I am able to succeed professionally. They've impacted all parts of my life.
I'm coming up to the anniversary of 5 years of rehab. Without the GoodHope Clinic, I'd have no hope.
I would hate to think of another EDS patient slipping through the cracks.
So that's just the start. This is the first time it's been played publicly, so we're going to certainly utilize that as we move forward, just to show what we're doing and to hopefully get some more resources and to continue the journey forward. So it's a journey together. We'll hopefully get there and get to a place where we significantly, hopefully, improve the care for EDS in Canada. So with that, I just want to thank you for all attending. It's a exciting two-day workshop put together by the planning committee.